Hello, I'm Dr. John McGann. I'm from the University of California, Davis Medical Center, which is located in Sacramento, California. Today, I'm going to talk to you about a problematic area, which is how do we diagnose etiologies of pain in the pregnant patients that are non-obstetrical causes of pain. I'm going to talk to you today about ultrasound and non-obstetrical acute abdominal pain. So I'm not going to talk about OB/GYN causes, but all other causes of pain. If we look at common causes of pain in pregnancy, this is basically the list. There's one thing I haven't included, which is more common cause of pain in pregnancy that we don't think about, and that's trauma. Overall, if we look at this list, overall there's about pain in pregnancy, non-traumatic, 1 in 500 pregnancies. What are our imaging choices? Well, ultrasound, MRI, and CT. But as you know, we're trying to get away from radiation, so CT is not looked upon as favorably, especially during pregnancy. We look at this slide and it basically, CT's out of control, or my cat's out of control here. CT, whether it's 20% or 30% of the examinations, and it produces 70 to 80% of radiation dose from medical use in the United States. Here's a study from Brown University, and the number of pregnant women scanned with CT increased by almost 90% in 10 years, and yet only 7% increase in admissions. So there's no doubt that CT use, even in pregnant women to this point, has been increasing. Now I have to go back to our physics a little bit, and basically we know that if you go ahead in the first trimester and have a 10 millisievert level for radiation to an embryo, there may be anatomical defects. But in fact, if you're at about the 2 to 3 millisievert level, which you are with a single CT through the pelvis, you can actually increase the risk of childhood leukemia. Nobody really knows what that is because there is a latent effect here of up to 20 years, but it is thought there's increased risk of leukemia in childhood from fetal or embryonic dose due to CT. As such, we want to limit that. Even the lay press, this is from USA Today, from an article in the New England Journal of Medicine, and they again talk about CT scanners and say in a few decades 2% of all cancers in the U.S. may be due to radiation from CT. So what do they recommend? A lot of different things. One of the things they say, well, what about ultrasound or MRI, which I'm going to talk to you about. Two principles. First principle, do no harm. In most situations, ultrasound probably should be the initial exam of choice. Second, establish the diagnosis when you have to, utilizing MRI, CT, or whatever you have to really think about both the health of the mother and the fetus. Well, one thing I didn't list was trauma, and that's really the most common etiology of pain in the abdomen in pregnant patients. How do we manage that? With a trauma fast scan, and a lot of times people don't think about the fast scan. If in fact we want to, we may even have CTs to the upper abdomen only to minimize radiation dose to the pelvis, especially during that first trimester. Trauma in pregnancy due to a number of causes, but certainly MVAs, assaults are high on that list. We looked at this and published our results in Radiology in 2004, and basically out of a number of different exams, over 2,000, we ended up with 23 with intra-abdominal injuries in patients that were pregnant. We basically checked free fluid, organ for abnormalities, and looked at the pregnancy as well. Sensitivity in the first trimester was very good. It was 90%. Sensitivity in the second and third trimester was very poor. And it's very surprising why it was poor. It wasn't because we missed splenic lesions or we missed liver lesions. It was because of abruptial placenta. If you put in the 6 cases of abruptio into our overall statistics, our overall sensitivity would have been 88%. I'm going to give a few examples here, and these are all pregnant women. So if you see fluid, even in the cul-de-sac in these pregnant women, it may mean something. And this was a lady who had free fluid in the cul-de-sac. We went ahead and did a limited CT, no operation, and she had a splenic lac. Here's another case, however, a 30-year-old woman, first trimester, free fluid in the right upper quadrant of the abdomen. We also identified free fluid along the flanks and both anterior and posterior to the uterus. That patient was taken directly to the operating room without a CT. A similar patient, a 22-year-old, with free fluid again anterior to the bladder, as well as free fluid adjacent to the spleen, and the spleen was very, very difficult to identify. She had a splenic lac and was taken directly to the OR without a CT. Here is the most common misdiagnosis to our surprise and our chagrin was this type of a case. And sometimes it is much more subtle, unfortunately. This is not a subtle case, but this is a case of abruptial placenta. And what are the findings? Well, I did a study years ago, and basically in about 50% of the cases, we don't see a lot, and I think that's really problematic in these cases. You look for a big hematoma, either intraplacental or retroplacental, clot adjacent to the placenta, thickened placenta, and in a rare case, you would see an intraamniotic debris or an amniotic fluid hemorrhage level. Well, what could be the future here? Well, just think if we could use contrast-enhanced sonography in blunt abdominal trauma, no need to do CT. However, it's not only not approved in pregnancy, but not even approved in the U.S. for abdominal use, except through IRBs. But here's a study we did a couple years ago. Here's a splenic lac. Here's what it looked like on the ultrasound without contrast. It was interpreted as normal. And here's the image that you can see with ultrasound contrast. You can very nicely see the very echogenic spleen with contrast and the hypoechoic laceration. We identified all splenic lacerations in our study. Here's another case in which you see a very complex splenic laceration, and here is the ultrasound image with contrast. Again, you can see this is a very complex injury with multiple hypoechoic areas through there corresponding to multiple small splenic lacerations. In fact, I actually think ultrasound better depicts the injury than CT does in this case. Other potential etiologies. So non-traumatic etiologies, always appendicitis is at the top of the list. Suspected appendicitis, we try with ultrasound, but eventually we may have to go with MR, and we try to avoid CT. Why do we have such a problem with ultrasound? Well, a couple different things. During pregnancy, the enlarging uterus may go ahead and push the cecum or the appendix up, or probably even more problematic is the uterus itself may overlie the appendix. We may never be able to really see the appendix with ultrasound. What do we look for? Same things we look for in the non-pregnant patients. So non-compressible, blind-ending tubular structure greater than 6 millimeters in diameter with an appendical lift and mesenteric stranding sometimes and free fluid sometimes. Ultrasound technique, I use a curved transducer, not really initially first for the appendix, but for other things, because we really don't know the etiology of the pain. Is it an ovarian torsion? Is it a renal problem, a gallbladder problem? Once I do really focus on the appendix, I use a curvilinear or a linear array for the right lower quadrant. I do a compression technique, and then I ask the patient where their specific site of tenderness is, and I may go ahead and do endovaginal, especially for the first trimester. Another thing that I do, and this is not a pregnant female, this is a male model here, but I push very firm, and then I sometimes put my hand behind the patient and scan upward from there. This is a case here in which we're scanning through the bowel, and you can see an echogenic focus with some shadowing. You may see an appendical lift, but this is compressible. This is the cecum in this case. Here is another case, and you can see a very small appendix, not that large. We really had problems with this. This is at 6 millimeters, but you note here there's a little free fluid in this case. And then we go ahead, and you can see that, and you see this small amount of free fluid. Then the longitudinal, you can go ahead and see it's a blind-ending tubular structure, not that large, but a little free fluid at the tip. And this ended up being very early acute appendicitis. This would be a very problematic case because it measured 6 to 8 millimeters depending on where you measured it. Here's a more common example, 29-year-old, postpartum, now with right lower quadrant pain, ultrasound very helpful. So you can see some of this increased mesenteric haziness or edema in there. And then you see the blind-ending fluid-filled tubular structure corresponding to acute appendicitis. However, if we look at statistics here, ultrasound certainly is not as sensitive for MRI for looking at acute appendicitis. Sensitivity in ultrasound in this series was only 36% compared to the sensitivity for MRI, which was 100%. How do we do our MRI? And basically we want to use some mildly T2 weighted image such as a single shot fast spin echo if you're using GE, which corresponds to a Hay sequence on semen, express on picker, etc. So there's all sorts of different acronyms used for that. And then we'll also throw in some sort of a fast T1 image as well. Now, can we use gadolinium? Really, we can't use gadolinium, and use only if essential in pregnancy, especially in the first trimester, because it is shown to have teratogenic effects in pregnant rabbits. If we look at different classifications of drug by the FDA, a category B drug would be iodinated contrast or Tylenol. We could use those, but a class C drug is where there is adverse effects on fetuses that we in animals, but we really don't know in humans. So that would be IV contrast for CT. This would be gadolinium. We should not use this during pregnancy. Again, just like ultrasound for entertainment, MRI gives us such gorgeous pictures. We really should not do this for entertainment, but should be done for a strict indication. Well, what does the normal appendix look like on these single shot fast spin echoes? TI corresponds to the terminal ileum. You can see here the low intensity appendix, another shot here, low intensity appendix right there, and then a coronal reformatted image, again showing the appendix here. What do we really look for? And I really look for those T2 weighted images for increased signal intensity in the lumen where the fluid is, and then surrounded the appendix, only slight increased signal intensity in the wall. Here's an example from the literature showing acute appendicitis here. You can see that, and now you can see in this image here, you see the acute appendicitis, which is posterior to the uterus. You see how the wall is thickened, there's fluid within the lumen, and there's some surrounding fluid as well. Now I use this to show you the normal appendix in this case, and normal appendix compared to the other side of the abnormal appendix, and you can see the marked difference, sort of the dark appearance of the normal appendix, and then with the T2 weighted images, the increased signal intensity. Here's a case where there is an appendicle lift loaned to me by Fergus Cogley in acute appendicitis. So you see that dark appendicle lift in this case, but there is fluid within that appendix, and this is a case of acute appendicitis. Another case that we had in which we went back and forth, there was some uncertainty here because this appendix, as you see here, there's free fluid, but as they measured it out, it measured about 8 millimeters. There was some uncertainty. So what I did, I said, I will look exactly there. So we had a localizer already. So I looked first at the gallbladder, then I looked at the kidney again, not jumping to the conclusion this was acute appendicitis. And then later I found this blind-ending tubular structure. You see a little fluid here, and you see it transverse, measuring at nearly a centimeter. And you can see the correlation between MRI and the ultrasound in this case, and then this is the real-time image. And I think that real-time image really shows you that blind-ending tubular structure, which is fluid-filled, surrounded by fluid, with the diagnosis, which was acute appendicitis, which required appendectomy. Next etiology of pain I'm going to look at is acute cholecystitis. And what happens in pregnancy? Well, you get progesterone and estrogen. One causes relaxation of the smooth muscle, leads to bile stasis. The other causes formation of gallstones. So what you end up with in these cases is stones, or in this case, the rolling stones. So you have to look for these. They're increased. But many times you don't even have to have stone disease in this case, such as this patient who was on TPN, had sludge-filled gallbladder, had acute right upper quadrant pain, positive ultrasound Murphy's. She had a calculus cholecystitis that required cholecystectomy. Another case here in which there's fulminant acute cholecystitis. So there was cholelithiasis, sludge. There was also thickened gallbladder wall and pericholecystic fluid, as well as a positive ultrasound Murphy sign in this case. How do you manage these patients? Mostly medically, if you can, laparoscopic cholecystectomy, and only rarely would we ever do a cholecystostomy. However, back in 1992, we described the first case which we managed using cholecystostomy. And basically, this patient carried our pregnancy and our tube for another 10 weeks and delivered, and then had an elective cholecystectomy. She was very, very sick, a patient who could not go on to elective cholecystectomy during her pregnancy. This will show you the case here. As we go ahead, we see the gallbladder, we see the our ultrasound trocar needle placement here. Once we're in there, we slide the catheter off the trocar placed. Then after we're in there, we aspirate the bile, and this is where color flow may be used to aspirate the bile and show us that we're in the gallbladder. With the egress of fluid, we get increased color flow through that catheter. MRI may be helpful, probably not so much for acute cholecystitis, but for complications of cholelithiasis, such as biliary ductal obstruction. This is a normal example here. This is a 2D MRCP using a fairly thick slice, about 6 centimeters, and it only takes us 5 seconds. We can do wagon wheel that takes a bunch of slices. That'll take us less than a minute, or we can do 3D that'll take us a little longer. But you can see very nicely here the common bile duct, and you can see the rest of the biliary system. You can see the gallbladder. You can even identify the pancreatic duct. You can see how you can miss very small stones, but you can certainly say in this case there is no evidence of biliary ductal dilatation. And you can see very nicely the pregnancy here as well. Pyelonephritis and obstruction, again, ultrasound probably is the key here, and most of these don't come to imaging, and really they're imaged only if there's an unresolved event, because pyelonephritis is probably more common than stones. Again, when we do these with ultrasound, the kidneys, transabdominal, and then transvaginal lower ureters, and then in severe pain, if they think there is a stone, a stent may be placed under ultrasound guidance. Again, first the curved array transducer, and then endovaginal in the first trimester. If we're lucky, such as in this case, which is very, very rare, we're able to see the stone. I'd say this would not be our typical example. This would be a case in which we're very lucky. We see there's hydronephrosis and a stone as well. We described where we could go ahead and do percutaneous nephrostomy. We have done this in a number of cases in which the patient is very, very sick, and we've done a number of different things in pregnant patients, including a nephrostomy. Here's another case of a 14-week pregnancy in which they elected to do a stent from above. This is the stone that you can see right there, and this is the stent, no fluoro at all, and we are asked to stand by as they put a stent from the bladder up into that hydronephrotic kidney past the stone. Ultrasound completely without any fluoroscopy, therefore no radiation to that 14-week fetus. Another very interesting case here, right upper quadrant pain, And we looked at the ultrasound hydronephrosis, but is that hydronephrosis a pregnancy or is that real? Then we looked at the left kidney normal, and you look here, there's hydronephrosis, but there's also fluid around that kidney. Now, how did we really make the diagnosis? Well, first we did MRI, and we saw there's a jet on the left side. Then we did ultrasound, and I waited and I scanned myself for 5 minutes. Jet on the left side, nothing on the right side at all. This is just the real-time clip. So when you think about this as a simple test, showed complete obstruction in this case, so seeing the lack of jet on the right side demonstrated there was hydronephrosis due to a stone. Very interesting case. It was later on in pregnancy, and this was the left kidney, and you can see something very echogenic here, and these were the dilated calyces here, and they're full of something here. And this turned out the postpartum CT and MR. You can see a stone here. Again, what we saw in ultrasound. This turned out to be XPG. She was delivered virtually at 37 weeks when we discovered this. But look at how really nice the ultrasound correlates with the CT. So this is the pre-delivery ultrasound and the post-delivery reconstructed CT. You can see how nice they are, and they almost look exactly the same here. Again, MRU or MR urography can be used, but again, we can't use gadolinium. Problem right here, as you can see, as we get down more distally, if there's a stone here, we may miss it, because now we've tried to cut out some of that pregnant uterus, and in doing so, we're sort of overlapping the distal ureter here. So we can see if there's hydronephrosis, but we may not always be able to tell the etiology here. Again, no gadolinium is used. When we have renal obstruction, we get decreased renal blood flow, increased interstitial fibrosis, and again, damage. That's why we want this to be treated. A lot has been talked in the past about use of resistive index in renal obstruction. A recent article came out in the JUM, really said it's insensitive and quite controversial. And I would think in pregnancy it would probably be very insensitive. I found no specific studies in pregnancy. You have sort of the normal hydronephrosis of pregnancy versus the stones that may occur there. I think it would be very difficult. Another thing with MRI is we have the apparent diffusion coefficient, or the ADC, which is actually made up of both diffusion and perfusion, and it ends up, you can subtract the diffusion portion from the ADC and get the pure perfusion fraction. With that, you can actually see if there is decreased blood flow. So this is the regular ADC, in which there was obstruction on this side compared to the others, which I took from radiology here. And you can see it if, in fact, you did the perfusion fraction only. You can see there's decreased perfusion on the right of the obstructed as compared to the left-hand side. Currently, this is really only a research technique, and I don't think has really been put into clinical practice. And if necessary, if we can't figure it out, we have to go on to look at CT, and we can decrease the CT dose here. So we're looking at 1.5 millisieverts instead of 3 millisieverts. But again, you get a hydronephrotic kidney and the stone. A couple of final things. Bowel obstruction, ultrasound really plays no role whatsoever. Again, adhesions are the most common. MRI may be very helpful. This is an example of a small bowel obstruction on the left and another small bowel obstruction with MRI on the right. Again, ultrasound plays really probably not a major role. And then hepatic rupture may be related to pregnancy, or it may not be related to pregnancy, such as trauma. In trauma, this is a great example of hepatic laceration. Here you can see the echogenic clot as well as the free fluid and the hypoechoic area within the liver in trauma. However, there's the HELLP syndrome, which is hemolytic anemia, elevated liver enzymes, and low platelet count, in which you can also have problems in the liver. And in these, it's more of a hepatic infarction rather than any sort of laceration. So you get an unusual pattern. It's really a hypoperfusion area. You get peripheral model hypointense lesions throughout the liver. Eventually you can get hemorrhage and or hepatic laceration or rupture. So I'm sort of taking you through step by step all these different etiologies for acute pain in pregnancy, and I've not gone ahead and talked about any of the OB or GYN causes, but taking you through trauma and all the others. Again, almost in all these, ultrasound should be first, and then you can go ahead and try MRI or CT if needed. I think that's probably with a few exceptions, maybe hepatic rupture, bowel obstruction, MRI or CT may have to be used in these cases. Again, what we're trying to do is do no harm to either the fetus, and in these cases, ultrasound should be used, especially in the first trimester. However, if we have to, and we really have to, think about the optimal care of both the mother and the fetus, we may have to go ahead and use CT in these cases so we can end up with this at the end of the road. Thank you.